Welcome everyone today to the Factors Affecting Return to Work Following Low Back Pain webinar. My name is Tanya and I work with the Canadian Institute for the Relief of Pain and Disability as the project manager. And this is the 6th webinar in our Return to Work Stay at Work series, and we're very glad to have you here today. This webinar series has been made possible through the support of the Direct Access Program through the BC government. Just a few technical points this morning. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. There is no speaking back and forth with those of you who are attending, so if you have any questions, you can use the question box to submit any issues you might be experiencing with sound or connection, and also to ask any questions you have related to the presentation. We will collect all questions submitted throughout the presentation and have a Q&A session at the end using those questions. Any questions that are not answered in the allotted time will be answered and posted onto our blog. The presentation is also being recorded and will be posted on online on our website for free, and you'll be emailed direct links to both of those items when they're available. As I mentioned, my name is Tanya, and I'll be moderating the webinar today. My coworker Lisa Mighton will also be assisting with the question and answer session. And our presenter today is Dr. Ivan Steenstra. Dr. Steenstra is an associate scientist at the Institute for Work and Health in Toronto, Ontario. Dr. Steenstra hails from the Netherlands, where he earned his PhD from the Department of Public and Occupational Health. He has also worked as a human movement specialist, which is a combination of kinesiology and work health psychology. He left the Netherlands to accept IWH's Mustard Fellowship in Work Environment and Health, after which he joined the Institute's research staff. His research interests focus on return to work, low back pain, with the emphasis on predicting the duration of low back pain and tailoring interventions to achieve a fast and safe return to work. Dr. Steenstra, thank you for being here, and I'll hand it over to you.
Okay, thank you, Tanya. So my name is Ivan, or as my mom calls me, Ivan. Today I'll be presenting on a systematic review that we did that was supported by a grant from the Workplace Research and Innovation Program of the Workers' Compensation Board of Manitoba. What's the Institute for Work and Health? The Institute for Work and Health is a not-for-profit research organization based in Toronto, Canada. So we do research in two broad domains. So one is on preventing work-related injury, so making sure that people don't get injured. The other domain is improving the health and recovery of injured workers through research on treatment, return to work, disability prevention and management, and compensation policy. So this presentation, or this study, actually fits in the second domain. And our research is aimed to inform policymakers, workers, workplaces, clinicians, and occupational health, safety, and disability management professionals. And from what I heard from Tanya is that today we have a lot of clinical-oriented people and disability management professionals. So I hope you will enjoy the presentation. So this project, the people on this team, so that was me, Carol Kennedy, who did part of the knowledge transfer we did for this project, Cindy Moser, who's also from our knowledge transfer department, Emma Irwin, Kwambi Mahout, and Linda de Bruin, who was a student from the Netherlands, and my colleague Martijn Heijmans, who was doing his PhD when I was doing my PhD there, and was part of the team of the previous version of this project that I did as part of my PhD project. And he works at the VU Medical Center in Amsterdam in the Netherlands, where we both did our PhD. And so from CIRPD, there's Lisa Mighton and Tonya Heidt, who will help you out if you have any problems during the presentation. And they will tell me when I have to make some changes during the presentation. So what's the rationale? I'll have to move something on my screen. The rationale of this study was to identify high-risk cases that will likely benefit from earlier intervention. And so we do these systematic reviews, so you don't have to. Systematic review is trying to organize and structure all the literature that's out there on a certain topic. And since it's low back pain and return to work, there is just so much out there that it's just impossible for a practicing healthcare professional to actually keep up to date on a daily basis. It's just, there's too much research being published, and there's actually also a lot of lower quality research, so it's very difficult to get the really good studies and identify them and come up with a good summary of all the evidence out there. So that's what we've been trying to do in this study. So as I mentioned earlier, I did a similar review on this topic for my PhD thesis, and that included the research from beginning of research on the topic up to December 2003. And so we updated that review that was published a few years ago with more recent literature. So what did we do? We looked at workers that were off work because of acute low back pain, and they had to have sick leave or be on work disability for more than 1 day and less than 6 weeks, because we wanted to look at the early phase of work disability. Because the idea was that if you extend it and include every duration of sick leave or work disability, that you get a very mixed bag. So the idea is that somebody that has been on work disability for, let's say, 6 months differs quite substantially from someone that's been on sick leave or work disability for only 2 weeks. And we also only looked at studies that looked at one prognostic factor and return to work, and the return to work had to be an outcome in those studies, so that we didn't capture studies that were more descriptive in nature, that were only reporting on how long it took before people went back to work. So we could actually say, well, we're looking at factors that predict the duration that people are away from work. So we're looking at prognostic factors. So what determines duration of time away from work? So prognosis is the prediction of the future course of a disorder following its onset. And so we know what the disorder is. It's low back pain. We know what the outcome is. That's return to work, and we define the onset. So that's more than 1 day away from work and shorter than 6 weeks away from work. Normally in the workshop that we have been doing on this topic, we would ask you to tell me what you consider to be prognostic factors in this population. You can go over it yourself and write down a few factors that you consider to be important, that in your experience have determined the duration until return to work in the population that you might have been treating or were managing. So in short, we're looking at a prognostic factor, a span of time until the outcome return to work has occurred. And that's the kind of studies we're interested in for this particular study, systematic review. So how do we do that? So what are the methods? We have a predefined set of search terms. So I had one for my previous version of this systematic review. In recent years, prognosis has been a field that more and more people are involved in, and the methods in prognosis research have improved over the years. So we added a few search terms, and of course at the Institute for Work and Health similar studies have been done, so people from the Institute for Work and Health added all the search terms that they usually use in return to work searches. Then we do a scan of titles, abstracts, and possibly relevant full-text articles. And if there's some unclarity whether a study fits our inclusion criteria, we contact the authors. Next, two reviewers independently scored the quality of included studies on 19 items in 6 categories, and then we divided the studies up. If they had a score of 15 to 19, we would consider it a high quality study. 10 to 15 is moderate quality, and less than 10 is lower quality. I would never call it poor quality, because I know some of the authors that actually published the studies that were in that category. So I know that they did the best that they could. It's just that sometimes we are very strict. So what we next did was we defined levels of evidence. So we consider a factor to be supported by strong evidence if there are consistent findings for an effect or a lack of effect in multiple high-quality studies. We consider moderate evidence when there's consistent findings in one high-quality study and one or more lower-quality studies, or in multiple lower-quality studies. And we consider that there's insufficient evidence if there's only one study available, or inconsistent findings are available in multiple studies. So one study somewhat contradicts the other. So what did we find? In total, we found 4,947 papers that seemed relevant, and so you can imagine that you should be very happy that you didn't have to go through all those almost 5,000 papers, because it's quite a job. So we did that for you. And in the end, we found 29 of 28 relevant publications from 25 studies. So some studies published multiple papers from their database. 2 of those studies were from Belgium, which is just south of the Netherlands, and there were 7 from the Netherlands, 10 were from the USA, 3 were from Canada, 2 from Norway, and 1 from Greece. So the Netherlands scores very well in this overview, but maybe they did really bad studies, so I'm not going to say anything. So the mean quality score was a score of 12 out of 19. The minimum score was 6 and the maximum score was 16. So according to our strict criteria, even the best study in this field could actually be improved upon. So that tells you a little bit how strict we've been in our quality assessment. So there were 5 high quality studies, 13 moderate quality studies, and 7 lower quality studies. And in total, 204 prognostic factors were identified in those studies. So what do 204 factors look like? They look like this, and that makes your head spin a little bit. So we categorized those factors into 37 constructs, because it might be that they call it, that one study calls it slightly different than the next study, but that doesn't mean that it's a totally different construct. So we summarize that and classify them into 34 categories. And in our workshops, we ask our participants to, we give them cue cards, so every card has a construct on it, and we ask them to select them and tell us which category, according to them, is important, and which factor is not important in the prognosis of return to work. Because those 204 studies doesn't mean that all of those 204 factors were actually found to be important. They were examined, and some of them were for some of them the study found that they were prognostic and other factors weren't prognostic. So there were, in some cases, there was an association with the outcome, and in other studies, in other cases, there wasn't an association with the outcome. So what I'm going to ask from you now is we want to do a little poll, and now Tanya is going to take over. I selected 6 factors that we found in our study, in our systematic review, and we would like to know from you whether you think that it's prognostic for return to work or not. So the only thing you have to do is answer yes or no. There are no right or wrong answers. It's just your experience or your knowledge that we're asking, and so don't think about it too long. Just tell us yes or no, and so we can compare it with the findings that we got from the literature. And at the end of the presentation, I will also show you what your peers actually reported to us during the workshop, so we can actually compare what practitioners find and what we found in the literature.
Okay, this is Tanya again. I'm gonna run through all of the polls. There's 6 of them. As they come up, feel free to click the yes or the no to answer the question. First, we'll do depression. All right. Now we will move on to workplace modified duties. Please click yes or no. Okay, next we will do age. And next is fear avoidance beliefs. Next will be workplace psychosocial factors. And finally, lifestyle. All right, Ivan, do you want to go over these towards the end of the presentation when you get to talking about the results?
Yeah, we can do it at the end where I'm comparing it to the results that we got from previous workshops.
Perfect. Then go ahead and move on.
Okay. Okay, so now you have a little bit of a mindset where you've considered what is predictive and not, so it actually helps you to be maybe a little bit more critical about what I'm going to show you as the results from our systematic review. So what we found was that there was strong evidence, so consistent findings in multiple high-quality studies for an effect on duration of sick leave or time on work disability in the acute phase for recovery expectations. So I didn't ask you all of the factors as previously mentioned, but there was strong evidence for recovery expectations, radiating pain, sometimes that was mentioned as injury severity. So self-report pain most often on a 10-point visual analog scale. Self-reported disability, like with the Roland Morris Disability Questionnaire or the Quebec scale or the Oswestry. Modified duties, workplace factors, the physical demands, and especially the type of occupation, so blue collar versus white collar, the type of healthcare provider, and job satisfaction. We found 2 studies that found a positive effect of job satisfaction. But what happens often in these studies is those 2 studies were actually from the same author, and sometimes, but both were high-quality studies, so they qualify as being supported by strong evidence. So there was also strong evidence for no effect. So we found consistent findings in multiple high-quality studies for no effect of lifestyle, so things like BMI, number of hours of physical activity prior to the injury, things like that. Doesn't seem to matter for people to get back to work. Pain catastrophizing, that's a skill that's often used in more cognitive behavioral approaches of pain rehabilitation. And education. I'll have to move something up because I wonder about the chat. So there was moderate evidence, so that means that there were consistent findings in 1 high-quality study and 1 or more lower quality studies, or in multiple lower quality studies, for an effect on duration of sick leave in the acute phase, of workplace psychosocial factors, of claim-related factors like time till adjudication, job tenure, prior claim or injury, and there seems to be a little bit of a dichotomy between claim or more North American-based studies and sick leave studies that are mostly from Europe. So treatment-related factors and specifically the content of the treatment, and a factor called pain observation. So does the treating healthcare professional observe a certain type of pain behavior? And there was moderate evidence for physical demands by self-report, but most studies, however, reported non-significant associations. And my conclusion is always that it's very difficult for somebody on sick leave to actually self-report on how physically demanding his or her job actually is. So there was also moderate evidence for no effect on duration of sick leave in the acute phase for the findings from clinical examination, and there was moderate evidence for no effect of depression. And I always get responses from the audience that I can't see in this case about does that mean that clinical examination isn't important? No, that doesn't mean that clinical examination isn't important. It means, of course, people have to come to a diagnosis. But after having reached the diagnosis, it doesn't seem to matter that much. So things like having an MRI or not doesn't seem to matter in the acute phase. And depression, people with an elevated depression score in the acute phase do not seem to take longer to get back to work than people with a lower depression score. So in this case, my worry is always, so what's the chicken and the egg? Because we know that depression is important in the work disability process, but it might be that depression actually occurs later in the process. So if people are away from work longer, it's actually it could be that work disability is actually causing depression, but it's not determining the time until return to work, it seems. And we found that there was insufficient evidence, mainly because there weren't enough studies for the effect of language barriers, for work-relatedness of low back pain, or the supervisor's response to someone being on work disability. The fact that work-relatedness wasn't studied in enough studies is mainly because in North American studies, it has to be labeled as work-related before people can actually claim work disability. So there's no contrast in those studies. And in more European studies, like in the Netherlands, the 7 studies that are from the Netherlands, low back pain has to be work relevant. So it doesn't have to be caused by work. As long as you're not able to do your work because of your low back pain, you can actually claim sick leave days. So that kind of explains why there's insufficient evidence. So there was insufficient evidence caused by inconsistent findings in multiple studies for age, and unfortunately that's mainly due to non-report. Researchers tend to adjust for the effect of age and not report it in their findings tables. Sex was again mainly adjusted for but not reported for, or not reported in the tables that they normally provide. And there was insufficient evidence for fear avoidance beliefs. That's some studies found that there was actually no effect of fear avoidance beliefs, and there weren't any strong studies that actually reported an effect of fear avoidance beliefs. There were not enough high-quality studies that actually looked into the effect of pain medication. There were some lower quality studies that looked at the use of opioids, but it's inconsistent because we don't have enough high-quality studies to actually make statements about that just yet. And there was insufficient evidence for the overall effect of mental health on duration on sick leave. Okay, so we asked 4 workshops prior to this webinar about, we asked healthcare professionals and other professionals what they found to be important. And it's interesting to compare the 2 points of view because your peers actually reported in 30, so we had we put people in groups of 3 to 4 people, and they had to come to consensus whether a factor was important or not. And 13 out of 13 groups actually said that according to their experience, depression was an important driver of duration of sick leave. Well, at least they said that they found it to be very important in the work disability process. But from the evidence, what we summarized was that there was actually moderate evidence for no effect. And in discussing these findings with the participants in our workshops, we sort of came to the conclusion that they put it in the important category because it is very important in the work disability process, but they didn't make the switch to thinking about it as a prognostic factor. So does it mean that if somebody has depression in the first 6 weeks, whether that actually determines duration on sick leave? It is important, but in the first 6 weeks, that might not be a determining factor for time on sick leave. So it doesn't mean that people don't get back to work if they have an elevated level of depression in those first few weeks. Everybody also thought that psychosocial factors were important, and from the evidence from the review, we could only state that there was insufficient evidence, and that's you can blame the researchers, so you can also blame me for that, due to the fact that we all think psychosocial factors are important, but researchers don't seem to have a consensus on how you actually measure that. So what kind of questions do you ask people to try to capture that psychosocial aspect? So everybody uses different questionnaires, everybody analyzes it in a different way. So if I present this to my researcher colleagues, I always tell them to shape up and come to some consensus, because this is really not helping our field or helping professionals in the field. Everybody agreed that the workplace psychosocial factors, so workplace support and things like that, were important, and there was moderate evidence for that factor from the research, and it's mainly moderate evidence because we could still use a few high-quality studies that look at that factor to lift it to the level of being supported by strong evidence. I always try to highlight this one as being maybe the most important finding from this exercise, that we all agree that workplace modified duties are important, and that's supported by strong evidence. So everybody can support the idea that we need more workplace modified duties to actually get an injured worker back to work. The scientific evidence is there, the experience in practice is there, but unfortunately it doesn't always happen. 12 out of 13 groups, so that's close to 50 people that we asked about claim-related factors, thought it was very important, but it was supported by moderate evidence, and that's mainly because first of all, it's very difficult to actually study that type of factor, and second of all, it hasn't been done that often, because what we see is that most studies are very much patient populations, so they're often not based on. They often don't take the insurer or the work disability insurer perspective into account. 12 out of 13 groups found that fear avoidance beliefs were really important, but the evidence from the review shows that there's actually insufficient evidence. There's some higher quality studies that actually show that if adjusted for a number of other factors, there is no effect. And 12 out of 13 groups that we asked in our workshop said that kinesiophobia, so fear of movement, was important, but again, it's not supported by a lot of studies, but that's also mainly because kinesiophobia is only studied in a limited number of studies. So there was no consensus amongst the groups, but it's supported by strong evidence for recovery expectations. So I always say, well, if you ask your patient how long do you think it's going to take, that's a pretty strong predictor of how long it's going to take, and that's based on a study that I did myself. So there was in that study, an occupational health service asked their injured workers, do you think it's going to take longer or shorter than 14 days? And that was actually a very powerful factor that they could actually use in their case management. So pain was supported by strong evidence, but 10 out of 13 groups reported that it was important in their opinion. So that's still 10 out of 13 is still quite a few. Self-reported disability, same number, 10 out of 13. Workplace physical factors, 9 out of 13. Provider type, 9 out of 13. We had some really interesting discussions where people actually wanted to go in a little bit more in depth. So it's not about does the chiropractor do a better job than the physio. We had actually had a really good discussion where they said, well, there are providers that are just very reluctant in sending their injured worker back to work because they're a little bit fear avoidant themselves, which was kind of funny. So it's not about one provider type versus the other type. It's really there are fear avoidant physios and there are fear avoidant rheumatologists. So they were considering it in that way. And then in the end, radiating pain was considered to be important by 8 out of 13 groups. And radiating pain has been one of the earlier factors that have been studied. So having radiating pain below the knee does predict whether somebody's going to be away from work for a longer period of time. So I think we can go to the results that we did from the polls, Tanya.
Sure. So this is based on, we have about 54 people online, and for each of the questions, about 80% of the audience answered the questions. So
Okay.
for depression, we had 95% said yes,
Yeah.
and 5% said no.
Yeah.
Then for workplace modified duty, 81% said yes, and 19% said no.
Oh, that's interesting. That's a bit contrary to what the previous groups all said, but yeah.
And then on age, we have 57% said yes and 43% said no.
Okay.
For fear avoidance, we have 93% said yes and 7% said no.
Yeah.
Workplace psychosocial factors, 93% yes, 7% no. Oops.
Okay.
Sorry, I clicked the wrong button there. And lifestyle, 80% said yes and 20% said no.
Okay. So one of the things that we discussed with the other workshops was about fear avoidance beliefs. So one of the things, again, is a researcher thing. There's the fear avoidance beliefs model, which I think my Johan Vlaje, he's actually not a countryman of mine, he's Belgium. But so there's a psychological model that is discussing fear avoidance beliefs, and then there's a fear avoidance beliefs questionnaire. So the studies often use the fear avoidance beliefs questionnaire, but the people that actually came up with the fear avoidance beliefs model have written a paper about it, and they actually say that the fear avoidance beliefs questionnaire doesn't really capture the fear avoidance beliefs model. So the fear avoidance beliefs questionnaire asks people questions like, is your low back pain work related? Well, that's not really fear or avoidance or beliefs. That's just determining whether people can claim work disability benefits or not. So that could explain, again, if people are thinking about the fear avoidance beliefs model, that might very well be the case. I have to say that the fear avoidance beliefs model is mostly used in more chronic patients, where we decided to really focus on the more acute phase of work disability, and most theory and most studies on fear avoidance beliefs have been done more in tertiary rehab centers, so where people have been out of work for. I know that in the Netherlands, the people that go to the center where Johan Vlaje is doing his research, that some of them have been out of work for years. So again, if you look at acute versus chronic, fear avoidance beliefs might actually be more related to that chronic phase compared to the acute phase. But we might actually have to spend some more time in actually trying to measure or capture that fear avoidance beliefs construct when we look in that acute phase, because that hasn't been done properly up till now. So, okay, and then about depression, what I already alluded to was so it might be very important, but again more in the chronic phase. And I'm not saying that depression isn't important. So if somebody gets into the office with clear signs of depression, of course that depression should be treated. But what is done in those prognostic studies is that they often use a questionnaire that's screening for signs of depression, like the CESD scale, and based on that simple screen, you can't determine whether somebody is going to be away from work for a long period of time or not. But a lot of people actually see injured workers that are at a later stage of their work disability, and those people might actually qualify more as chronic patients. And in chronic pain patients, we know that depression is quite prevalent. But in the acute phase, it doesn't seem to be a prognostic factor for time away from work, as far as we can say from this research. So modified duties, 19% thinks it's not important. So that's a little bit different from what we found in the previous workshop. But that might be because I spent more time with those people and they know that I did research on modified duties and the effects of interventions. So I might have biased them in favor of workplace modified duties, but because I think that it's also supported by intervention studies like the Sherbrooke model, and we did a replication of the Sherbrooke model in the Netherlands, and we also could show that it actually is effective in getting people back to work in a safe way. So I think it's interesting to see these results, and I think it would be interesting to get to some Q&A. So some questions, and hopefully I can give some answers. On the last slide, I'm providing some links to the report for this study, and a best evidence synthesis that that Cindy and her colleagues actually make, that can be found on the website as well. So you don't have to go through the entire report, and you can actually share it with co-workers just by showing them the sharing best evidence summary that we provide. And finally, you can also sign up for our quarterly e-alerts and newsletters. You can follow us on Twitter. That's Cindy Moser is doing most of that work, and we're on LinkedIn, so you can link with the Institute for Work and Health and some of our educational influential networks that we have on there. Okay, thank you.
Wonderful. At this point, we don't actually have any questions, so if people want to submit any questions they have through the questions box, then we can have Ivan answer them. Let's see. Okay, we did just get one. Are prognostic indicators for acute versus persistent pain different? And it sounds like it is.
I think it is, but I will know for sure because based on the workshop that we did in Manitoba and some of the other workshops we did, we actually got that question. So what about the persistent pain or the chronic pain phase? And I said, well, you know, when I was a PhD student, I had this idea of first doing the acute phase, then the subacute phase, and then the chronic phase. And I saw my whole career worked out, but I have never done that next step. So I wrote a proposal for the granting agency in Manitoba, and they actually funded our next review, where we're going to look at whether it's different in the persistent pain or chronic pain phase. And what I can see now is that it was kind of smart of me to first focus on that chronic phase, because everything beyond the 8 to 12 weeks, it all gets a little bit messy if in a research way of thinking. But what I now see is well, we still have to do the full analysis, but we do see some different factors show up in those studies that look at the chronic phase. So I think they are quite different.
Very good. Any further questions that people want to ask? By typing them in through the question box. What are your thoughts with the Start Back screening tool?
I think that's a wonderful tool, and I would like to do a validation of that tool in Canada. I'm very curious who's asking that question, because that's a comment I got when I sent in a proposal to CIHR. Why aren't you validating the Start Back tool? So that Start Back tool is a screening questionnaire that's developed by my colleagues at Keele University in the UK, Jonathan Hill and colleagues. And they developed a prognostic tool, a screening tool, and divide people up in low risk, medium risk, and high risk. People that are identified as being low risk are getting reassurance and a little booklet, and are sent home and say, you're going to be okay. And people that are labeled as medium risk get exercise therapy, and people that are labeled as high risk are getting thrown everything we know at them. So they get cognitive behavioral therapy, they get exercise therapy, and I think they also get some education. That tool was studied in a randomized controlled trial, so some people got the tool and were getting their usual care as they always did in the UK, and the other people got the screening tool and then got the intervention that they were triaged to. And it showed that people that were triaged into a certain type of treatment, that group actually did better than the group that didn't get triaged to a particular type of intervention. So the improvements are on pain and disability. But I asked Jonathan, so what's up with the results that you are supposed to have on work-related outcomes? And he said, well, he said to me in an email, well, we're probably not going to publish those. And they did use them in their cost-effectiveness analysis, and it showed that their approach is actually more cost-effective. But I'm afraid that we will not find their effectiveness on work-related outcomes published anytime soon. So it's very promising, but mainly on pain and disability. And I'm not sure what their effectiveness is on work-related outcomes. So return to work.
Okay, this is Lisa. We have a few more questions coming in. One here, with regards to work-related injuries, WSIB, the Workplace Safety Insurance Board, will send out letters citing a recovery date and a return to pre-injury date. What is the standard recovery?
What is the standard recovery? I don't think there's such a thing as a standard recovery. But I might get in trouble now. It's so dependent on what prognostic factors are present in that particular patient. So if you would have no risk factors whatsoever, it might be very quick. But if you have a lot of risk factors, if you have physically demanding work, if the panel thinks that age isn't important, but maybe if you're older, if you have a workplace that doesn't offer you modified duties, there might not be a standard time till recovery, or at least, yeah. So I think you have to be very careful coming up with a standard recovery time. So I don't see strong research evidence that supports a natural recovery time for those cases. So.
A question from Lance. Can you elaborate a little on the types of workplace psychosocial factors that may have been evidence for return to work?
It was mainly focusing on whether, if I recall correctly, whether there were any policies in place for return to work in the workplace, and I think that whether there was a supportive supervisor that was supportive of return to work. I did look at, because of another project, I looked at co-worker support, and there wasn't strong evidence for that, but that's also because, again, a measurement issue is that we don't really ask people how co-workers support their return to work. We ask whether they have nice colleagues, and that's just such a general question that you will find no effect of such of a factor if you ask it that way. So, but it was mainly based on policies that were in place, and I think supervisor support.
We have a question from a person with chronic pain. She says, I know I don't fall within the present criteria. I have had long-term spinal injury, 3 years now, been able to avoid surgery and can now live without ongoing pain if I'm very careful. I've been actively involved in my rehab for these last 3 years. Do you know what percentage return to work after such a long recovery?
No, I don't. That's the blunt answer. But I it's so I don't know the percentage, but I think if like that recovery expectations question, if somebody wants to get back to a type of work, the chances are can be good. But it's really dependent on people's individual characteristics. So I believe that if you have a job that where you can actually where you have some decision latitude, where you can do your own hour, you can somewhat determine your own hours and can actually determine how you actually organize your own work, that people with chronic pain or chronic conditions can stay at work. So, but there are no numbers as far as I know. I can ask one of my colleagues that is more focused on chronic conditions, but I don't think that that we have numbers on that group of patients.
Oh, Lisa, I think you might have muted yourself.
Can you comment on the literature that is indicating that depression is a greater predictor of chronic lower back pain versus disc protrusions?
Say again, did I mute myself or did I just hear
No, that was me.
Okay.
She says, can you comment on the literature that is indicating that depression is a greater predictor of chronic lower back pain versus disc protrusions?
Well, I know that the thing about disc protrusions is that that's a diagnosis that's not always very meaningful, because there are people that have slightly bulging discs that have no pain whatsoever, and there's people where you see a little bit of an abnormality on an MRI or on some kind of imaging test. So the diagnosis isn't very meaningful in that sense. So comparing depression to protrusions can be it's a little bit difficult to say, well, one's more important than the other. I think depression, you know, the whole thing about causation is quite difficult, because in chronic pain you don't know what actually came first. It's not that people were very depressed and next became chronic pain patients. I've had back pain for a bit, and I stayed at home for a while, and that didn't really help me in my mental health at all. So it's very difficult to actually compare depression with disc protrusions, because there's quite a bit to say about disc protrusions, and I don't think that they're so different that you can't really compare the two.
From Christine, it may fall into the psychosocial factors, but I'm wondering if you have found any correlation between time in a job pre-injury and return to work time.
So time, what was it? The time pre-injury? What?
Between time in a job pre-injury and return to work time.
Oh, that would be what some people call job tenure. And if I recall correctly, my colleagues at Liberty Mutual always find job tenure as being prognostic, and it's like that job satisfaction question. The job satisfaction question, that they are one of the groups that always find job tenure to be prognostic, and others don't. And I hold my colleagues from Liberty Mutual in high regard. So I don't know what's going on that they always find it to be important. I can understand that if somebody is more connected to the workplace where they get injured, that it's in a sense it's easier for them to actually get back to work. So in that sense, I can understand that they find that relationship. But they are one of few research groups that actually do find it.
Okay, there's a question about whether you can speak to the Oribro musculoskeletal pain questionnaire and whether you use it and your thoughts on that.
That's Stephen Linton's questionnaire, so I do know it. We just we've co-published with the people from Liberty Mutual on a new questionnaire where we also try to subgroup people and direct them towards specific interventions. What I understand from Stephen Linton is that he is ready for something new. So that's why he's involved in the studies with Bill Shaw. What I see if I look at the literature is that they did all the testing, and they were reasonably accurate in predicting return to work in Sweden, and I think also in New Zealand. But I also came across a study by a master's student, or I thought it was a pretty good thesis. I was first thinking it was a PhD thesis from McMaster's, and she looked at the Uribro questionnaire in, I think it was New Brunswick or Nova Scotia, and she found that it didn't have the same, it didn't predict return to work that well in that province. So it might have performed quite well in Sweden in a rehab setting, but what I saw in that study that unfortunately hasn't been published yet was that it didn't behave in a Canadian setting. So it wasn't that prognostic or that predictive in a Canadian setting. So and from Stephen Linton, I know that he thinks he could improve on that particular questionnaire. So I think he's been working on that for so long, so it's quite something that he wants to improve on his own work, where half the world is actually using it. So I hope that's a question. That's an answer.
Is another question from Bernadette: is assessing psychosocial yellow flags in acute lower back pain helpful?
Well, that's what the whole world says, so how could I disagree? Yeah, I think looking at yellow flags is really important. But the whole flag system, so the red flags and the yellow flags and blue flags and black flags and what, I don't know which colors we have now. Often it's based on treatment of low back pain, and it's not always very work-oriented. So some of the workplace factors are, of course, we now have the blue flags, so then they do try to look at workplace-related factors. But often those aren't always mentioned in the yellow flag. So I think the workplace-related factors actually deserve their blue flags, and so I agree that yellow flags are important, but in work, so if you look at return to work, it hasn't been studied very systematically, and then there's a lot of opinion actually there's a lot of consensus, and I would like to do the research to support it, but I think it could use some more support, some more scientific evidence when return to work is concerned.
Very good. Well, we are at about time to end now. So I want to thank everyone for joining us today, and thank you very much, Ivan, for your presentation.
Thank you.